Hello, my name is Annamaria Brioli, and I'm a medical doctor at the Greifswald University Hospital in Germany. And today I'm gonna talk with you about lymphoid blast phase of chronic myeloid leukemia. These are my disclosures. I think the first questions that we need to ask us when we are discussing blast phase of chronic myeloid leukemia is, do we really still need to talk about blast phase in the area of tyrosine kinase inhibitors? We know that since the introduction of tyrosine kinase inhibitor in CML, blast phase has reduced from 20 to less than 5%. On the other hand, despite the improvements in CML treatment, we have long-lasting remissions. We are discussing about treatment-free remission, in which patients can we safely stop treatment. Still, patients with blast phase CML will perform poorly, as can be seen from this study done on patients enrolled in German clinical trial. And the problem is that as this disease is so rare, prospective clinical trials and standard treatment protocols are lacking, which means that we do not have precise treatment recommendations and the treatment is not standardized. If then we think about the lymphoid blast phase, it gets even more complicated, as lymphoid blast phase is more rare than myeloid blast phase. It forms about 1/3 of all CML blast phases. Lymphoid blast phases are mainly of B phenotype, mainly precursors B cell phenotypes, although there can even be T cell phenotype lymphoid blast phases, although these are extremely rare. There are about 50 cases reported. Another important aspect is that we need to distinguish lymphoid blast phase from Philadelphia positive acute lymphoid leukemia, as the prognosis is different and patients with lymphoid blast phase should receive all of them an allogeneic stem cell transplantation. And this differentiation can be tricky. There are a few aspects which are helpful in differentiating lymphoid blast phase from Philadelphia positive acute lymphoid leukemia. Obviously, a previous history of chronic phase of CML. If there is a peripheral basophilia, splenomegaly, the presence of an E13A2 or an E14A2 transcript, a left-shifted leukocytosis. Another aspect which can help us to differentiate a blast phase, a lymphoid blast phase of chronic myeloid leukemia from a acute lymphoid leukemia is if there are discrepancies between blast measures in flow cytometry and BCR-ABL transcript level. We might have a negative flow cytometry, but still of positive BCR-ABL transcript levels. And that is because BCR-ABL is present in cases of lymphoid blast phase, also in the myeloid series. And obviously, if we can confirm the presence of BCR-ABL or of the Philadelphia chromosome by FISH in the myeloid series in these patients, we have another data which tells us this is a lymphoid blast phase of a chronic myeloid leukemia and is not an acute lymphoid leukemia. The biology of blast phase is extremely complex. The progression from a chronic phase to a blast phase is due to complex biological interactions. We do have secondary translocation, we have double-strand breaks, we do have epigenetic alterations, we have mutations in gene that regulate for transcription, and we will see that this also has a role in the development of lymphoid blast phase. This leads to a reduced apoptosis, to a self-renewal and growth of the cells, which in the end brings to an impaired differentiation and the development of blast. And as you can see, this is a continuum from chronic phase to accelerated phase to then blast phase. If we look at the biology of blast phase, can we differentiate myeloid blast phase from lymphoid blast phase? Let's first have a look generally of the cytogenetic of blast phase of chronic myeloid leukemia. We know that about 60 to 80% of the patients with a blast phase of chronic myeloid leukemia do have additional chromosomal aberration. The most frequent aberration are trisomy of chromosome 8, an additional Philadelphia chromosome, rearrangements of chromosome 3, deletion of chromosome 7, and isochromosome 17q. Now, importantly, as you can see here, deletion from chromosome 7 and rearrangements of chromosome 3q have increased and have emerged as more common additional chromosomal abnormalities since tyrosine kinase made their way into chronic myeloid leukemia therapy. They moved from very few to up to 15% of cases with myeloid blast phases. Also important is that most additional chromosomal abnormalities are present in association, which means within a complex karyotype. But if we look at the cytogenetic abnormalities, we also know that there is a difference between myeloid and lymphoid blast phase. Rearrangements of chromosome 3 are prevalent in myeloid blast phase. On the other hand, deletion of chromosome 7 or chromosome 7q have a higher frequency, as you can see here, pointed by the red arrow, in the lymphoid blast phase. And we know that these patients do have a higher risk of developing a lymphoid blast phase, as can be seen here. These are patients with different chromosomal abnormalities, and these are patients with deletion 7, 7q, and you can see there is a higher risk of developing a lymphoid blast phase. And this is true before the tyrosine kinase inhibitor, but also in the tyrosine kinase inhibitor era. Other important cytogenetic abnormalities are mutations. Obviously, as we said, we mainly in lymphoid blast phase, we have to do with mainly B and in some cases T phenotype. We do see in these patients rearrangement of the immunoglobulin or the T cell receptor. This is an analysis of more than 100 patients with lymphoid blast phase and myeloid blast phase. The orange here are the lymphoid blast phases, the green are the myeloid blast phases, and you can see very clearly immunoglobulin rearrangement and T cell receptor rearrangement are more frequent in the lymphoid blast phase. But you can also see already from this quite busy figure that there are differences in terms of molecular profiles between myeloid and lymphoid blast phase, although some alterations, as for example, ranks 1 mutations or deletions, are present in both lymphoid and myeloid blast phase. For example, one of the alterations that we know is more common in lymphoid blast phase are deletion of P16, ARF, or RB mutation or deletions. And here we can see it more clearly, these differences between lymphoid and myeloid blast phase. You can clearly see, we already said, deletion 7p is more prominent in lymphoid blast phase. Deletion 9 is also more prominent in lymphoid blast phase, but also deletion of Icarus zinc finger. If you remember, one of these transcription factors which are important in the progression toward blast phase, or deletion of CDKN2AB are more prevalent in lymphoid blast phase. And importantly, when we look more in depth into lymphoid blast phase, we also see that some of these alterations co-occur. For example, CDKN2AB can co-occur with deletion 7 or deletion 9, as you can see from the red boxes highlighted from the red and the blue boxes in this figure. And this co-occurrence of this alteration is highly specific of a lymphoid blast phase, which means when we do have this alteration, it's very likely that we are dealing with a lymphoid blast phase and not, for example, with an acute lymphoid leukemia. Now, let's move to the treatment of lymphoid blast phase. I've said already at the beginning of this talk, treatment is not standardized. This disease is very rare and we do not really have clear treatment recommendation. And this is depicted very clearly in this slide. You can see a lot of different trials which use a lot of different drugs, whether tyrosine kinase inhibitor alone or tyrosine kinase inhibitor in combination with different kinds of chemotherapies. But what you can see is the number of patients is extremely low. In some of these cases, there is a mix between lymphoid blast phase and Philadelphia positive ALL, and the trial does not allow us to distinguish in the results which are the lymphoid blast phase and which are the myeloid blast phase, which are the acute lymphoid leukemias. We can see that the combination of tyrosine kinase inhibitor and chemotherapy does increase the rate of responses compared to tyrosine kinase inhibitors alone, and also improves prognosis. Nevertheless, prognosis remains poor. We can see here the median overall survival ranges from 7 months, half a year, to about 1 year, 1.5 years. So quite dismal outcomes. We also have some trials with other drugs, for example, bosutinib, or combination of third-generation tyrosine kinase inhibitor and chemotherapy. The problem of these trials is that we still have really a low number of patients with lymphoid blast phase. 30 patients enrolled, only 6 patients with lymphoid blast phase. In some cases, we actually don't know how many patients had lymphoid blast phase in these trials. Or we had, for example, 17 patients and only 4 patients with lymphoid blast phase. And the responses that are shown here, they actually deal with the whole population, which means we cannot really dissect what is the outcome of lymphoid blast phase versus myeloid blast phase in these cases. But here again, we can see, we do see responses about 50% of the patient with a complete cytogenetic response, for example, with a combination of ponatinib and FLAG-IDA, but outcomes are still dismal with an overall survival, median overall survival of about 1 year. There are new kids on the blocks coming. We know this from trials on acute lymphoid leukemia, antibodies, monoclonal antibodies, or bispecific antibodies, for example, inotuzumab or blinatumomab. Here, there are only, unfortunately, reports on an extremely low number of patients, 1, 2, 3 patients. Data seem promising, one has to say. Of these patients, the majority responded, but again, the number are extremely low. But this could be a promising treatment to a bridge to transplantation. We have to notice that with these drugs, although we do achieve responses, the duration of response is definitely lower than if we don't perform allogeneic stem cell transplantation, than the duration of response that we see in the cases of acute lymphoid leukemia. Now, I would just like to show you 2 examples of the treatment of lymphoid blast phase. One is the trial which I've just already mentioned, and this is an attempt from the colleague of the United Kingdom, especially the group from Mike Copeland, to standardize treatment for lymphoid blast phase. Patients with blast phase of chronic myeloid leukemia, doesn't matter if lymphoid or myeloid, were randomized, were receiving treatment with ponatinib, a third-generation tyrosine kinase inhibitor, and FLAG-IDA chemotherapy, and they were then recommended to receive allogeneic transplantation and receiving ponatinib maintenance after allogeneic transplantation. Median follow-up of the trial is 41 months. We can see that 8 patients completed 2 cycles of FLAG-IDA from the 17 who had been included. 12 patients, which means 70%, proceeded to allogeneic stem cell transplantation, and in these patients, median overall survival has not been reached. On the other hand, one has to say that the performance of patients who did not proceed to allogeneic transplantation for whatever reason is extremely poor. All 5 patients died within 7 months from trial begin, and the median overall survival of this population was only 2 months. Importantly, 30% of the patients, of course, the numbers are very slow, but I think that's promising data, did achieve a major molecular response after 1 cycle of ponatinib FLAG-IDA. Toxicity can be a concern. We need to be aware of that, and we need to take care of that. 3 patients died during the study. Cardiomyopathy was a problem, pulmonary hemorrhage, or bone marrow aplasia. Nevertheless, for fit patients, this standardized treatment with a third-generation tyrosine kinase inhibitor in combination with a chemotherapy could be an option for patients with blast phase, whether lymphoid or myeloid. In Europe, we are currently running a registry of blast crisis to really try to depict what is done in clinical practice, because this disease is so rare and because we don't really have clinical trials. And if we do have them, they're, as I've just shown you, on a very low number of patients. And these data were presented at ASH last year. And what you can see, this cartoon here just depicts the complexity of treatment. Patients received up to 9 different combinations, and we couldn't really see a pattern into that. What we did notice is that, as could have been expected, probably the more used treatment combination was a combination of tyrosine kinase inhibitor chemotherapy and allogeneic stem cell transplantation, followed by tyrosine kinase inhibitor and chemotherapy. There were really few patients who did not receive tyrosine kinase inhibitor at all. In total, only 7% of the cases. And there were also few patients who did not, about half of the patients did receive an allogeneic stem cell transplantation. Looking at tyrosine kinase inhibitor, I think these slides depict quite nicely what is the panorama in all Europe, in all the countries who have also different accessibilities to different drugs. We do have a third of the patients who in the blast phase do receive imatinib treatment. The most used tyrosine kinase inhibitor are, however, dasatinib and ponatinib, as probably could have been expected. They are more newer tyrosine kinase inhibitors. Now, in the trials, we had more than 200 in this register, we had more than 200 patients included, which means we could also really try to have a look at which factors do influence treatment choice in reality, in real clinical practice. And some of the factors could have been expected: age, previous history of CML, presence of BCR-ABL mutations. But importantly, what we did see, and I think in this case, this is quite an important notion, that the phenotype of blast phase, whether lymphoid or myeloid, also did influence treatment choice, which means patients with lymphoid blast phase were more likely to receive chemotherapy. And from the data that I've shown you, it's obvious that these patients were more likely to receive chemotherapy in association with a tyrosine kinase inhibitor, as only 7% of the patients did not have tyrosine kinase inhibitor, and only 4% had chemotherapy alone. And if you look at the tyrosine kinase inhibitor, patients with lymphoid blast phases were more likely to receive dasatinib. The reasons still need to be dissected. This is an observational study. This is a register, so we are actually depicting what people do in reality. But in reality, one has to say the phenotype of the blast phase already does influence treatment choices. And of course, we need to collect more data and to dissect that more clearly to find out what are the reasons of these choices, and is there also a biological rationale behind it? And these are all things that are currently work in process to better understand this disease. Now, let's move on. We've talked about responses. I've already mentioned quickly the outcome of lymphoid blast phase, but how does lymphoid blast phase perform, for example, in comparison to myeloid blast phase? And data from a retrospective analysis of the MD Anderson Cancer Center on almost 500 patients, 477 patients, who were collected between, let's say, the emerge of tyrosine kinase inhibitor. Patients were seen between 1997 and 2016, did show that actually lymphoid blast phase has a better outcome compared to myeloid blast phase. Overall survival is about twice as long in patients with lymphoid blast phase compared to myeloid blast phase. This, as I said, are patients collected between 1997 and 2016, which means as the tyrosine kinase inhibitor were making their way in the treatment of both chronic phase of myeloid leukemia and on blast phases. But what happens in more recent year? Can this data be confirmed? Actually, yes, they can. And these are data, again, from this European Blast Crisis Register, which I just mentioned you about, more than 200 patients. And this is important. Patients enrolled in the registry all at the blast phase, which was diagnosed after 2015, which means these are a blast phase who emerged under tyrosine kinase inhibitor therapy. And there are two things which I think we can see from these slides. On one side is that the general overall survival has improved from the data that I showed you before. It's still not good. It's still a dismal overall survival, less than 2 years, but it's still about 10 months longer than the overall survival, which I just showed you before, which were about 1 year to 17 months. But what we could confirm with this data was that lymphoid blast phase do have a better outcome compared to myeloid blast phase, with an overall survival which is almost double as long. So to conclude, lymphoid blast phase is still an unmet clinical need, if possible, even more than myeloid blast phase, as it's even rarer and is even more complicated to dissect data from the reported clinical trial, which, as you have seen, have really a few number of patients. The molecular pathway involved in the progression of blast phase are different. Myeloid blast phase has a different molecular pathway than lymphoid blast phase, as I've showed you, although some features can be shared, as for example, mutation of RANKS1, but other features as deletion of Ikaros ring finger, deletion of chromosome 7 or chromosome 9 are more prevalent in the lymphoid blast phase, and for example, other alterations as ASLXL1 or alteration of chromosome 3, arrangements of chromosome 3 are more prominent in myeloid blast phase. It is important to differentiate lymphoid blast phase from Philadelphia positive acute lymphoid leukemia, as the first have the worst outcome and need to proceed to allogeneic stem cell transplantation. We have seen the data from the Matchpoint trial. Patients who do not have received an allogeneic stem cell transplantation have an overall survival of 7 months, less than 1 year. As I've mentioned, due to the rarity of this disease's treatment, standardization is difficult. A promising option are probably second or third generation tyrosine kinase inhibitor with ALL-directed chemotherapy, and allogeneic stem cell transplantation could be the best option for patients who can afford, who can actually tolerate this kind of treatment. Monoclonal bispecific antibodies are a new option. They are, I could say, they could be the new kids on the block coming, although their efficacy is lower, as of course, these drugs do not target the myeloid compartment and the leukemic stem cell, and we should not forget that in the lymphoid blast phase of chronic myeloid leukemia, the myeloid compartment and the leukemic stem cell do harbor the Philadelphia chromosome, the T922 translocation, and this is the population that we need to target if you want to eradicate the disease. There are also other options that I've not mentioned here, which are coming and which could be promising, and we need of course, to collect more data. And these are, for example, asciminib or BCL2 inhibitors, which could target the leukemic stem cell, or even combination therapy with bispecific antibodies and chemotherapies and tyrosine kinase inhibitors. This combination with these three different compounds are currently being studied. Trials are ongoing, studies are ongoing, and this could improve patients' outcome. I would like to finish just acknowledging all the colleagues who did collaborate in the Blast Crisis Registry, who are still collaborating in it. As you can see from the faded map behind all the names, this is really a huge effort with a really lot of countries included, which could really help us to depict the reality of blast phase and also to dissect the differences between myeloid and lymphoid blast phase. And I thank you all for your attention.